Without any further ado, let's begin this session, which is dedicated to neurodevelopment disorders and addictions. So it is unusual, but I will abstain from taking part usually in scientific sessions when I organize the Congress, but this is an exception when it is about meeting with the Dual Pathology Organization, and when I have the opportunity to meet with my friend and mentor, Miguel who's coming from Barcelona, and he is going to give you a vision on the content of this session. Hello, everybody. Thank you very much, Jean-Pierre. Hello to everyone. In 2 minutes, I would like to give you a brief introduction to what represents the disorder in neurodevelopment today. These are disorders that are psychobiological and interfere with the learning and behavior. These are disorders that have supported the evolution of humanity. They've always been existed with a great prevalence for people, for 18% to 22 in children, 12 to 15% in adults. These are figures that are very high, and it's not very comfortable to know that 1 out of 5 children is suffering from these disorders, and 1 out of 8 adults. But the good news is that if we reflect on youth, and we want to we can start reversing some of these disorders. So learning disorders, 8 to 10%, ADHD disorders, 5 to 7%, and of course it does exist. People wonder, but it does exist. The autistic spectrum, communication disorders, psychomotor disorders, etc. One of the specificities of these disorders, usually that there's a comorbidity. They appear in comorbidity with others. It's difficult to see the ADHD. Well, there's dyslexia, of course, dysgraphic, dyscalculation. And we always need to think that when one of these disorders appear, we need to check whether there's a comorbidity and other issues. Children, adolescents, and even adults suffering from this disorder will not just only have a learning issue, but also this is what we see very first. This is what we can detect, and this is at school. Then there will be emotional disorders. Why? Because for 10 years, from 6 years of age until 16 years, when it's mandatory to go to school, every day, people, they're told, why can't you read? Why aren't you working? Why do you not, why aren't you, why are you creating all these disorders at school? Be nice to your brother, etc. And they don't follow what you're saying. Why does the headmaster call me because there's a problem at school? So for 10 years, this is horrible. Every day, if you hear this, even during the weekends, even during holidays, and finally, these children, they like to work in order to try to change and reverse these issues for 5, 6, 9 years, and they try to change things around, but sometimes they realize that they cannot do better at school, they cannot do better with facing these behavioral issues. So these emotional disorders, that's what come next after the difficulties at school, and with a complication with anxiety, depression, and finally, at 15 or 16 years of age, there we see appearing addictions to cannabis stimulants as self-medication. because they're going to try to change around this issue. What we are going to talk about today are these addictions to cannabis stimulants as self-medication and a form to compensate for these neurodevelopmental issues that our children are facing. Thank you. Very well. So the first speaker is Professor Gabriele FISCHER from Vienna. She is very used to coming to these ATHS symposiums. She's a longtime friend of mine, and Gabby is going to talk today about use issues of these ADH problems, hyperactivity issues or disorders. And I'd like to remind you that she attracted the attention for a long time on this problem. And specifically, she had very early underlined that in prisons, jails, and treatment centers as well for addictions, but in jail, this disorder of ADHD and hyperactivity was overrepresented, and that this non-diagnosis and non-treatment represented in her mind, and we totally agreed with her, represented a breach in human rights. So she is going to tell us about this issue. So Gabby, the floor is yours.
Thank you very much. First of all, let me express my gratitude to be here. It's such a wonderful meeting organized by wonderful people. Thank you so much, Jean-Pierre, ATHS, and also Cecilia for organizing everything. And it's my pleasure, actually, being here on stage with friends. And I would just want to refer to Miguel. I was as young as 35 years when I first met Miguel and came to Barcelona. I was working there for European Parliament, looking in the situation, how the drug situation and treatment for women is. And I was really nervous, and he, the boss of the psychiatric department, picked me up from the airport, drove me about 3 or 4 hours to Barcelona, showed me Barcelona, ending at the clinic, and he says, now we go for siesta, and then we start working on the evening. So it's really a pleasure, not only my French friends, my US friends, but especially thank you so much for Miguel treating me so nicely many, many years ago when I started to do my research career. Thank you. So I should be, yes, it's working, yeah. Part of them Miguel was already referring to, so substance use disorder and ADHD, there's a strong connectivity, not only related to substance themselves, but also to other behavior like gambling, gaming, and also we heard Mark Potenza yesterday about the high affinity towards other tools like TikTok, Facebook, etc., related to ADHD. And you find on the bottom of the slide, you also find eating addictions. Eating addiction, Nora Volkow has been addressing this for decades now, and it did not make this to the classification system, but we have a lot of neuroimaging results and clinical results who show actually the correlation towards food addiction and obesity, and more research is coming up actually with new medication. I don't know whether I make it until the end of the talk, but there is something on tomorrow. So it's really a broad scenario we have to cover if we talk about substance use disorder, not directly substance related, and ADHD. You find on this screen on the upper right side, might be very familiar to Sir John Strang. It's a British prince who is actually looking into kind of mental health and addressing it, because one of our problems, and Miguel was addressing this a long time ago, ADHD is there. We have to look into comorbidities, and we don't have really role models who advocate, who go out there. And there was last year, there was the Clinton Foundation gave a presence on mental disorders, and actually Prince Harry addressed this, and he committed to a continuous education on that topic related to young people, adolescents, and internet use and mobile phone use, etc. It was pointed out already, and with ICD-11, we do have actually the first time to diagnose next to substance use disorder, we can relate to gambling disorder, gaming disorder, and other specified disorders due to addiction behavior. So I don't know how it's in France. Unfortunately, the ICD-11 version has been out for 2-3 years now, but it's not available in German yet. But we still, I think, have to really stick on with this system to really diagnose these disorders. And before I go into detail, my conflict of interest related to the topic, I have the pleasure of being on a board together with Professor Wim van den Brink on a company in Israel looking into psychedelics. Then I'm at a board of a wonderful psychotropic organization, which is called Neurotorium. I invited to look into this organization. There are wonderful grants you can apply, and there's wonderful educational material down there. And I'm also at the scientific committee of AUDA. On the opening, you saw Alexis Gustel, who gave a presentation on the European Union market. And we try very hard to focus on comorbidity and substance use disorder, as the agency still is very much related to focal points who deliver the data, but we need to go into depths, what is related, what's the underlying reason of substance use disorder. Drugs are chemicals that affect brain and mind. Here in the audience, everybody knows this. We know that the rewarding effects through drugs relate to the dopamine release in the mesolimbic system with projection to prefrontal and orbitofrontal cortex, the regulation of motivation and cognitive control, independent whether it's related to direct substances or non-substances. And I see colleagues making pictures. My slides are available. Just call the agency here. They have my slides, and they are happy to share them. And next to substance use disorder, where dopamine plays a significant role, we do also have ADHD, where we are aware of, and it's proven by science over and over, that there is a disturbance in the dopamine transporter. We got these imaging results decades ago showing the interaction of what's going to be happening if there is substance use, what's going to be happening in the mesolimbic system with dopamine and the dopamine transporters. But next to dopamine, and I don't know whether Wim is going to be touching this in his presentation, there are also other neurotransmitters involved in this kind of chemical disturbances. You might be aware of these wonderful graphs. First saw them by Nora Volkov from NIDA, just picturing what's going to be happening in the addicted brain versus the non-addicted brain, referring to the neurobiological features, showing the deficiency, what's going to be happening, why people just cannot stop, why people need to continue taking drugs in order at the beginning to stabilize them and keep going on for a significant and severe destabilization. I got this picture from David Nutt. He presented on this, showing also next to the biological disturbances, to the consequences of the loss of control, to the negative consequences. And he referred to Frida Kahlo. You might know her. And she once stated, "I tried to drown my sorrows in alcohol, but they learned to swim." And I think this is the bottom line. We need to listen to our patient. We do know the consequences, but very often, if you have on the one hand side substance use disorder clinics, it's heavily neglected to look into the high burden of psychiatric comorbidity. ADHD is picturing, and everybody who is dealing with it, we do know that's an impression, clinical impression of anger, dysphoria, loss of impulsive control, low frustration tolerance. These young kids, and what for me is mostly very much impressive, they complain from the early beginning on about significant sleep disorders because of their circulating thoughts. They don't let them sleep. And when I started to look into ADHD and substance use disorder, one of my first impressions was having people with heavy cocaine consumption. They came to my clinic, they told me they really take cocaine on the evening. They're not going to go out with this drug. They remain at home. They feel very empathetic, and they are able to sleep. So I think one of the key variables is what I have been learning over the last 20 years, looking in both disorders. Listen to the patient, do a clear exploration, and you will really get to know what's going on, because somebody who really is a cocaine addict without ADHD is using this drug on a totally different way. ADHD is multifactorial. One of the factors we tend to forget is the polygenetic etiology. You have to look into family patterns. I keep actually, if I have young patients on mostly related to high stimulant or cocaine abuse and ADHD, the wife of the mother of the patient says, listen, I think some of the behavior are here in my husband, but he's not taking cocaine, he's taking alcohol, he's drinking too much alcohol. So it's very interestingly, you find adult ADHD who there are different levels of performance, but there is a significant familial loading if we look into this. The same is in substance use disorder. What we tend to forget that there is a kind of a heavy genetic loading in the substances, and we have a swift in the substances abused over the generation, even related also to in another generation to gambling disorders. Attention deficit disorder, Miguel already pointed it out, it persists into adulthood in 50 to 65% of the cases, and very often people don't know it for a long time, that they have a significant impairment. Very often they first come with a problem related to drugs. And what also Miguel was referring already to it, it's not just, it's a major burden for the individual. It's a major burden for the public health. If we just relate to the high traffic accidents related to ADHD, and for the and if we relate to the high percentage of prisoners with ADHD, very often together with substance use disorder, not to forget the much higher mortality rate in the individuals with ADHD, and also related sexual risk behavior. I don't know, but I think quite many of you might be knowing Gabor Maté. I don't know how old he is now, but he's a Hungarian psychiatrist, and he wrote books because he was suffering himself severely on substance use disorder. Mostly he smoked a lot of cannabis. Until then, he had a lot of problems going to school, going to high school, going to medical school. Then I think he moved first to the United States, then to Canada, and then he really got diagnosed and treated with ADHD. And this is a fantastic book. It's available in German, it's in English, it's in French. I usually tend to give these family members to read this, to understand this. And he's also touching the issue that his sons are suffering on ADHD, and early treatment intervention is really not just bringing a quality of life to the individuals, but it's making a career without substance use. As 50% of the patients with ADHD do have on board substance use disorder next to many other comorbidities. And of course, the longer it lasts until you diagnose and treat them adequately, the higher the comorbid conditions are occurring. The reasons for increased substance use, increased impulsivity, problematic peer groups, social problems, students dropping out of school very early, and substance use, refer again to Miguel, in his opening statement as an attempt to self-medicate. When we are doing from the public health perspective education at school, very often teachers tell us, well, the adolescents are doing much better on Mondays and Tuesdays because they still, in quote, benefit from their intensive cannabis consumption over the weekend. So I think it's still partly I see esoteric reports, which make me very sad. We have to take this condition very, very serious. And this is probably one aspect why we have to try to integrate substance use disorder in the whole psychiatric spectrum, and not only looking in addiction clinic on the dependence on the individual substances, but looking into the comorbidities, because it's not easy. It's not an easy task to treat, whereas it's very much rewarding to treat them. Yes, ADHD is linked to an early start of substance use, more severe addiction, an increase of psychiatric diagnosis, a higher probability on suicide actions, and an increased amount of hospital stays. It's important to diagnose and start treatment with both conditions. And it's a rewarding effect to initiate treatment. And very often, and I think Nick referred yesterday in the cannabis panel to it, well, there was an emotional discussion whether methadone is the right medication because it has a dependence potential itself. So it's still I hear this, to get, if we have somebody maintain on opiates and give the person methylphenidate or amphetamine, it's still a discussion. Isn't this too dangerous because it has an addiction potential? The person who needs it, don't misuse it. And why is it important? And I don't go into detail. It's very important. If we negotiate getting more money, we need to negotiate the costs related to ADHD and substance use disorder to political entities. Because ADHD and substance use disorder, both in socioeconomic calculation from the United States and from the European Union, they are one of the most expensive disorders, not because our medication is so expensive, but because of the high indirect costs, dropping out of school early, especially in the combination of both, and a significant amount, unfortunately, really ends up in prison. And as we know, it's the most important place to have patients there. I briefly just give you a clue what is very often forgotten, namely alcohol. Cannabis, if you look into ADHD and substance use, cannabis is by far the most frequent abused substance, followed by stimulants, cocaine, and hallucinogenics. But if you look into alcohol dependence and ADHD, it's depending on the study, it varies with a prevalence from 20 to 50%. You might be aware the normal prevalence in the general population is 3 to 5% in adults. So it's highly underdiagnosed, it's underestimated, and the columns over there just illustrate, give you a clue, the dark columns show the loading of ADHD in a cohort investigated 3 times of the high percentage of ADHD in alcohol-dependent patients. And about equivalent, not as high, but an equivalent pattern you find in young persons with cannabis abuse. And cocaine is by far the drug what is really liked by patients with ADHD because of the much stronger ability to release dopamine. And these are data from an ADHD clinic. They looked how in a meta-analysis, how often do we see cocaine use? We see it to 26% and prevalence of cocaine disorder 10%. There are a lot of studies out there. I bet Dr. Wim van den Brink is touching them, but there is very nice control studies how superior it is to treat this dependence with ADHD and methylphenidate compared to placebo, and the early start of treatment leads to lower consumption in adolescents. The same pattern, no surprise, we find in gambling. The prevalence of ADHD in pathological problem gamblers is 25%. We did a study in my clinic looking into problem-seeking gamblers. We found this high prevalence. Of course, it's the equivalently outcome. If there is ADHD on board, it's a major gambling problem, higher level of gambling related to cognition deficiencies, more psychiatric comorbidity, and higher suicidal risk. Medication-wise, in substance use dependence in ADHD, we have the data on methylphenidate compared to controls, where there's still the systemic review says in minors and adolescents, it's the primary drug of choice, whereas in adults, amphetamine is the is a recommended drug of choice. And CASAS, where Dr. Wim van den Brink is part of this group, is referring to the recommendation of amphetamine, of long-acting formulation of amphetamines, if there is ADHD and substance use dependence on board together. Just to give you a quick jump in, Facebook. Facebook use is nothing for adults anymore. Mark Potenza pointed this out yesterday. It's more, I would say, my generation, a little bit younger, but there is a strong correlation. ADHD predicts addictive Facebook use, and negative predicts future orientation in adolescent users. Men score significantly higher than women, and there are also recent studies in the last year looking whether there is association of ADHD and hypersexuality and paraphilia. There is no support for that because it's a very heterogeneous study design, but there is a strong support on intensity of ADHD predicted all problematic online behavior, from shopping, gambling, social networking, cybersex, online gaming, cyberchondria, of course, in women, as to expect. Sex predicted lower scores in online gaming and cybersex. And if you look in a huge cohort in internet gaming disorder, it's again the same result: high prevalence of ADHD, high association between attention and internet gaming disorders. Again, as a high correlation towards substance use disorder, you find this underlined depression and anxiety. One result is less affecting parenting styles, but to be honest, if you have untreated adolescents, ADHD youngsters, it's really, really very difficult for parents to remain balanced. It's even more difficult if the issue of substance use disorders comes together. Finally, we should not forget ADHD and forensic psychiatry. ADHD is associated with the risk of intimate partner violence. There is a study showing the positive outcome looking over a duration of a year if ADHD is treated successfully. And prison, you find on the PubMed, unfortunately, less and less research is being done on these cohorts, but knowing, and I've been doing with my group research in prison, it's going to be very, very difficult to do under these circumstances research, but there is a high prevalence on substance use disorder and a high prevalence on ADHD. Can I keep this going? Yes. This just underlines between men and women, you see the high amount of alcohol use and drug misusing inmates in prison. And the most common comorbidities in people in prison with ADHD is substance use disorder. And again, I'm done in 5 minutes. Yes, thank you. Again, the high prevalence, 25 to 30% of the prisoners relate to ADHD, which we confirmed in a study looking into opioid-maintained patients in prison. So they were already on opioid maintenance, and opiates do have some influence on ADHD, but it's not the adequate treatment for it. But just to allude, there were 133 inmates, 50% were positive for childhood ADHD, and 17% were positive for ADHD, and only 3% had ADHD medication. So no surprise that it's very, very difficult in regard to behavior control in these settings if there is not adequate treatment in this condition. And I'm coming now to the end. Even there are nice data by Susan Young showing that the criminality rates in individuals with ADHD while on and off medication, there's a high influence. Being on medication is not only that the relapse to substance use decrease after prison release, also the criminality figures decrease. So this is again a tricky discussion, making amphetamines available in a prison setting, which seems to my point of view very important. And at the end, I touch obesity in the issue of food addiction. We used to have, these are the data, the number of deaths by risk factor 2019. You find very high up obesity. You find related somatic aspects and you find alcohol use close by and kind of lower drug use. Yes, these are the screens. So eating disorder, when we treat quite some obese patients, refer to our obesity clinic checking for binge eating disorder, which is a frequent consumption of large amount of food within a short period. And most of the time, they don't eat because they are hungry. They eat rapidly and basically to overcome negative feelings. So the clinical pattern is very closely related to substance use, to the clinical features of substance use disorder. And there's a lot of comorbidity on board of these food-addicted patients. And there are some studies referring to the high load of ADHD. And what we do in my clinic, what is really very beneficial, we are not using GLP-1 agonists, but we're also using lisdexamfetamine. And it's very nicely, if you look into the outcome, and I would love to have some studies published. There are some studies coming out, some positive studies with alcohol dependence. I would love to have this support from funding for obesity, food addiction, and ADHD. And most of all, we have the high stigma in young children. Thank you very much for your attention.
Thanks a lot. Very important to emphasize all these very crucial issues. Maintenant, nous allons donner donc la parole à...
Now we are going to give the floor to Professor Wim van den Brink from Amsterdam. He is also from Biarritz, each year at least, and we thank him for his faithfulness to ATHS and for his friendship. He is going to, well, in line with what was just mentioned by Gabi FISCHER, he is going to speak about pharmacotherapy effects and psychotherapy, finally. So in the treatment of patients suffering from disorders linked with substance use and ADHD as comorbidity. He is going to give us the first results of the cohort results of the International Review on the ADHD, INCAS. The floor is yours.
Like Gabi, I would like to express my gratitude to both men here. I must remember the great hospitality of when I came to Barcelona, and it looks very much like your experience. And that I also experienced already for many years here in Biarritz. It even came as far as that Jean-Pierre borrowed me his car one day. So it's an unbelievable hospitality that you encounter here. And the trust, most of the time he says to me, come to the meeting and you prepare something. So there is a big trust. He even entrusted one of his patients to me when she came to Amsterdam or to the Netherlands. So thank you very much for the invitations again here. And so I'm very happy to present for the first time, I think, some results from the INCAS study. And it's a study on predictors of treatment allocation and treatment outcomes of patients with a substance use disorder and a comorbid diagnosis of ADHD. So these are my disclosures. I often say that I'm polymorph perverse. I do it with everybody on all kinds of different ways. And so it doesn't make me less of a criminal, but these are my potential conflicts of interest. I think today I have none of these, but you should know that I have these. So what will I discuss with you? I first say a few words about our organization, which is the International Collaboration of ADHD and Substance Abuse. It's an organization that's existing for a few years now, and we did the study in the context of that collaboration. Then we will very briefly say a few words about substance use disorder and ADHD and the treatment of this comorbidity. I've told these things before in this meeting, but I need to say that because based on these results, we once wrote a consensus statements about the treatment of substance use disorder and ADHD. And the study that I'm going to present today is really looking into the fact whether these statements on the treatment of this comorbidity actually take place in reality, in the real world. I also will look a little bit about what it means for patients if they are treated like we propose to treat them. So this is INCAS, the International Collaboration of ADHD and Substance Abuse. We wrote a little paper in European Addiction Research about the mission, the first results, and the future activities. INCAS is existing since 2005 with an official foundation since 2020. And currently we have 59 participant institutes from 32 centers in 20 countries in Europe, but also the US and Asia. Our mission is to decrease the risk of ADHD patients developing substance use disorder and to improve the detection, diagnosis, and treatment of substance use and ADHD. That's quite a big mission, isn't it, for a small group? We have been doing studies, epidemiological studies, the ES1 and 2. We're doing some consensus statements, and currently we're in the publication of our last study, which is a study on the treatment and prediction of outcomes in these patients. So if you look at substance use disorder and ADHD, this is much broader, much shorter than Gabriele has did it. Substance use disorder and ADHD, they frequently co-occur. If you see it in the clinic, 15 to 25% of all the treatment-seeking substance use disorder patients have ADHD. So this is a huge comorbidity. It's obvious that they share genetics and underlying neurobiology. Early stimulant treatment of ADHD can prevent the development of substance use disorder. I think a very important message, especially if you start this stimulant treatment at an early age and in adequate dosages. ADHD definitely has a negative effect on the treatment of substance use disorder and vice versa. And to say, and that is worrisome, relatively little is known about the treatment of substance use disorders with comorbid ADHD. So this is what we try to deal with. What is it about the treatment of substance use disorders and ADHD? I think this was a rather recent study. It was a retrospective cohort study with about 203 patients with substance use disorder and ADHD. And they were looking at the retention rate of people staying in treatment. And what they showed very clearly is that substance use or the patients with ADHD, if they use ADHD medication, they stay in treatment much longer than the ones that don't use the ADHD medication. Now, the question is, do they have better outcomes? You can stay longer in treatment, but what does it mean if it doesn't have a positive effect? And then comes a quite sobering slide, and this is this one. It's from 2017 already. It was a review from a Dutchman, Jan-Pieter Carpentier, and the famous Francis Levin. And they did a literature review on the pharmacological treatment of ADHD in addicted patients. And the pharmacological treatment, mainly with stimulants, and mainly in patients with a drug use disorder. That is very clear. There were very few studies in patients with alcohol dependence or cannabis use dependence. But what they showed from all the randomized controlled trials that they looked at is that there was very little or no effect of the treatment of ADHD, symptoms, and no effect on substance use, except if you start to use high doses of stimulants. But that was only done in patients with stimulant use disorders. So this was a very sobering, this is the overview of the study. It's a very sobering, if you look at the slide, I'm not sure that they can show that. Yeah, maybe here, yeah. If you look here, these were the studies, randomized controls, and here you have the effects on ADHD, here you have the effects on substance use disorder. Normally, if you treat patients with ADHD, you see all pluses here. But you see here, there's not a lot of pluses, actually. Normally, you see some effect of such. You see there's nothing here. Except for these two studies, And you see, these were the studies, one from Constantius from Sweden with methylphenidate, high doses up to 180 milligrams in amphetamine use disorder patients, and one from Francis Levin from the US, mixed amphetamine salts in coke-independent patients. So they see effects both on ADHD and on substance use disorder. All the other studies were mainly negative. And so there is some explanation, I'm not going into that, but it seems that if you want to treat patients with ADHD and substance use disorder, for their ADHD, you might need higher dosages, at least in a lot of patients, than the normal standard doses. So this is known. These are actually the two studies that really show that higher doses of either methylphenidate or amphetamine salts are associated with much better outcomes in terms of both substance use disorder symptoms and ADHD symptoms. I added one recent study from Australia where they looked at lisdexamfetamine. They definitely show that in this comorbid population, you can actually use higher doses without severe side effects. So they didn't show the effectiveness, but they really showed that high doses of lisdexamfetamine in these methamphetamine-dependent patients led to a reduction of methamphetamine use. But they didn't show the effect on ADHD because they didn't measure it well enough. So this is actually a miserable situation if you think that since 2017, there have been no studies on ADHD and substance use disorder and the treatment of them. So as an INCAS, we started to think that something has to be done. Oh, I have to mention this. We were involved in some study in looking at cognitive behavior therapy for this specific group of substance use disorder patients with ADHD, and we showed that integrated CBT could actually be done, and it has a good effect both on substance use disorder patients, substance use symptoms and ADHD symptoms. So that brings me to the international consensus statement that we made some years ago. This was published in European Addiction Research in 2018. And what we said on, we had all kinds of recommendations about screening, diagnosis, but also on treatment recommendations. These were the recommendations. Adequate treatment of both substance use and ADHD should be performed. Don't wait for the one or the other, but start immediate treatment of both disorders. Use a combination of integrated psychotherapy and pharmacotherapy. Stimulant treatment or atomoxetine for ADHD with higher doses option, if possible. And be careful with the clinical manager to prevent abuse and diversion of stimulants. So we say use stimulants if you think that is useful, but be careful about abuse and diversion. So now we wanted to know what happens in reality. Do actually people in treatment follow up these kind of recommendations from the literature? So this the study was presented, the design of the study was presented about 3 years ago in BMC Psychiatry. And these were the aims of the INCAS study: to describe the treatment modalities received by substance use and ADHD patients, to describe the difference in outcome from different treatment modalities, to identify predictors for retention in treatment, predictors for ADHD symptoms, and predictors for substance use, and to derive hypotheses for the future randomized trial, because we still think that we need more randomized controlled trials. This was the design of the study. It was a naturalistic prospective study. Population was 578 substance use disorder patients with comorbid adult ADHD. Recruitment in 9 countries. Assessment baseline 4 weeks, 3 months, and 9 months follow-up. Outcomes in terms of treatment retention, substance use using the timeline follow-back, ADHD symptoms using the ASRS, and improvement in social functioning. Predictors were type of treatment, with or without stimulant treatment, with or without psychotherapy, and a lot of treatment, potential treatment modifiers. These were the baseline characteristics of that study. As I said, 578 patients, 137 females, 441 males, 47% inpatients, 52% outpatients. Most common substance use disorder were alcohol, stimulants, and cannabis. 47% had two or more comorbid substance use disorder. Of course, 87% had regular tobacco use. We often forget that there's probably one of the most significant comorbidities. Quite a lot, because we recruited them in substance use disorder agencies. 71% had received substance use treatment. That is not a surprise. But this is quite bad. Of these patients, only 41% had never received any ADHD treatment. And 61% had at least one additional comorbid mental disorder. So what happened in these studies? And we published some early results last year in Journal of Clinical Psychiatry, looking at what kind of treatments people got offered. And this is the kind of substance use treatments that these comorbid patients received at baseline or in the first 4 weeks of their treatment. And what you see is that in terms of pharmacotherapy, 39% of the patients received any kind of substance use disorder treatment, which varied by the kind of the substance use disorder. Opiate use disorder were treated with pharmacotherapy most often, 43%, but still, quite a lot were not treated for their opiate use disorder. Alcohol use disorder, a shocking 28%. We have good medications for alcohol use disorder treatment, and only 28 was treated. Stimulant use disorder, 17%. That's actually quite amazing, because we have no recognized treatments for stimulant use disorder. And tobacco use disorder, shockingly low with 6.7%. But then if you go to the right side, what you see is the site variation. I told you it was in many different sites in Europe and the US. And then what you see in terms of the pharmacotherapy for this substance, in Switzerland, it was only 25%, whereas in Spain, it was 91%. If you look at opiate use disorder, in Sweden, it was 17% of the opiate use disorders. Patients were treated with a substance use medication, and in Belgium, it was 100%. So you see a lot of variation. If you look at the tobacco use disorder, we always think that they do very well in the US. They did the best, but still only 29% of the patients were treated for their tobacco use disorder. Now for their ADHD treatments. What kind of ADHD treatments did they receive? Pharmacotherapy, 54%. Stimulant treatment, that's one of the pharmacotherapies, 41%. Psychotherapy for ADHD, 34%. Combined pharmaco and psychotherapy, that is the recommendation, only 25%, and combined stimulant treatment with psychotherapy, only 17%. And here again, you see a large variation in the different countries. What for me was quite amazing was that if you look at the pharmacotherapy, you see the US did very well with 90%. But then if you look at the kind of pharmacotherapy, in the US, 21% was only stimulant, whereas in France, for example, it was 75% stimulant therapy, although stimulant therapy is maybe the most effective kind of treatment. So the US is doing very well in treatment, but in terms of the type of treatment, maybe it's not optimal. Maybe people are afraid of the abuse potential in this population of stimulant treatment. And you see again, large variations in the type of treatments that are offered in the different countries. A variation that shouldn't exist, I guess. What are the predictors of these kind of treatments? We looked at a lot of variables, and basically what we found is that the most important predictor whether people got ADHD treatment or not was study site, was the country. That was the most important predictor, which is not a scientific one. It's some of different feelings in different countries about what kind of treatment is acceptable. The predictors for ADHD treatment reception was also related to the severity of the ADHD. You see, if they have a higher ARSRS, if you have a higher severity, you have a bigger probability that you get treatment with stimulant treatment. An important factor was also that in order to get stimulant treatment, you had to be completely abstinent at the beginning of the treatment. So people were willing, or treatment physicians were willing to prescribe stimulants, but only if you were already totally abstinent. And you see a big odds ratio there. So the question of that is really what we should go for, waiting for people to become fully abstinent before treating them with stimulants. This is what happens if you follow them over 9 months, and you see the pharmacotherapy for substance use disorder. Actually, they go down from 39% to 24%, maybe because they think it's effective already after a few months. Pharmacotherapy for ADHD was very stable over time. If you started that pharmacotherapy, you did it over the 9 months. The same was for stimulant treatment. If you started it, actually, you remained on that kind of stimulant treatment over the 9 months. If you look at pharmacotherapy for other mental disorders, you see it's going down quite dramatically. And maybe that is because they respond quite quickly to these treatments, and people feel that you don't need long-term treatment of depression or bipolar disorder or so. Whether that's correct or not, but this is what you see in this population. Now, you see that people are being treated, not all of them, but some are treated. Some are even treated the way we want them to be treated, but has it any effect? And that is what we studied in these naturalistic prospective studies over 3 to 9 months. And here you see the predictors of retention, and we have many predictors, and they're all, you can see them here, quite a lot of predictors, and here I show you just the significant ones. Actually, treatment retention was mainly predicted by ADHD treatment. If you got ADHD treatment, you had a better retention. And that effect was driven completely by stimulant treatment. If you got stimulant treatment, you remained longer in treatment of these patients. There were also some other predictors. So stimulant treatment had an odds ratio of 2.4, so the probability that you remained 3 months in treatment was 2.5 times higher in the ones that received stimulant treatment than in the ones that didn't receive stimulant treatment. Comorbid pharmacological treatment, so treatment of depression and other, was actually also a strong predictor. And employment, if people were employed, they had a much better chance to remain in treatment than people who were not employed. These were the only significant predictors. Treatment of a reduction of at least 30% in ADHD symptoms at 3 months. We looked at it, and again, the most significant predictor and the most important predictor was stimulant treatment. People who were treated with stimulants had a much higher, 3 times higher chance to have significant reductions in their ADHD symptoms than patients who were not treated with stimulants. We found that something that we cannot explain yet. If you had a benzodiazepine use disorder, you had a much worse effect on ASRS. So anybody who comes up with a good explanation for that, tell us. We don't understand it really. And again, sight was an interesting predictor of that. Then looking at significant predictors of the number of heavy drinking days, we only looked at that in patients with not all substance use disorder, but who had an alcohol use disorder and ADHD. The number was 376. And here you see an interesting, there are more predictors, but I only show you the ones that are significant or of good relevance clinically. The main message again is fewer heavy drinking days are seen in patients with psychological and or stimulant ADHD treatment. So treatment of ADHD, either with stimulants or treatment with psychological intervention, is producing lower numbers of heavy drinking days at 3 months, and actually we looked also at 9 months, even at 9 months. So if you look at this and you compare it to what we had in our recommendations, then the conclusion of this quite large study says that in contrast to our recommendation, only 39% of these patients received pharmacotherapy for the substance use disorder. Only 54% received pharmacotherapy for ADHD, and only 41% received stimulant therapy. In the US, it was a nice finding that 100% of the ADHD received pharmacotherapy for the ADHD, but only 21% received stimulant therapy. It was also an interesting finding, and we have to discuss that stimulant therapy was largely restricted to fully abstinent patients when they reached the therapy. And only that was the most important recommendation, combined pharmacotherapy and psychotherapy of ADHD. That was only 25%. There were large site variation. They were only partly due to sample difference and have no scientific or clinical justification. Very important to note, I think, that stimulant treatment has positive effects on ADHD symptoms and on alcohol outcomes. Predictors of retention were stimulant treatment and employment. Prediction of ADHD outcome was stimulant treatment. The predictors of alcohol outcome were sex, age, ADHD severity, housing, and stimulant treatment of ADHD. Of course, there are strengths and limitations of this study. The strength is it's a real-world multinational study with a prospective observational design. So this really shows what happens in reality and not in the laboratory of a randomized controlled trial. It's a large sample of treatment-seeking substance use patients with comorbid ADHD, and we have fully standardized follow-up assessment, of course. The fact that it's a real-world study is also a limitation. It's a real-world naturalistic pre-post design, but there is no randomization there. So also a limitation is that we use clinical diagnosis of substance use disorder. Now, we're not afraid that people who come to an addiction treatment center that they don't meet criteria for a substance use disorder. They don't come if they don't meet criteria. The other thing is with the ADHD, it was also the clinical diagnosis, but we looked at the ASRS symptoms, and without exception, they had very high rates, very high scores on the ASRS symptom measurement. Of course, there's a risk of residual bias or confounding in this naturalistic study. Although there was some relatively high dropout, we have no indication of attrition bias. We didn't see any main difference between the ones that dropped out and the ones that remained in treatment, except for the ones that, the fact that they were treated more often with stimulants. There's also no indication of indication bias. Since treatment allocation was only predicted by study site and not by other variables. We have no detailed information on drug use. We only asked for drug use and not for specific drugs, so that's really something that we have to look at it more carefully. Unfortunately, we don't have from our patients information on medication doses. We would love to know whether they had normal doses or higher dosage of stimulants or atomoxetine, but we don't have the information. We did not do a correction for multiple comparisons so far because this is an observational study and the study is actually made to obtain new hypotheses. So my summary and conclusion, ADHD is a frequent comorbid disorder in treatment-seeking substance use disorder patients. Only a small fraction of the comorbid ADHD was recognized and treated before the study. The treatment recommendations were not always, I would say, were often not followed, with low stimulant prescription and low combination of stimulant prescription with psychotherapy for ADHD. Stimulant treatment was often, almost always restricted to abstinent patients and not to patients who were still actively using drugs or alcohol. And stimulant prescription turned out in this study to be the most important predictor of positive outcomes. So, thank you for your attention.
Thank you, Wim. Ces résultats sont passionnants.
Thank you very much, Wim. Your results are fascinating. They open up they're paving the way for our discussions now. So, I'm going to give the floor to Professor Maurice DEMATTEIS from Grenoble, and he is a neurologist, but he is the most psychiatrist in our neurologists. He's also a pharmacologist and professor in pharmacology, and he is the head of an addictology center at the CHU in Grenoble. the hospital in Grenoble, and I'm very touched. He has accepted this invitation because he was confronted to very difficult events, but he is here and we can count on him, and I would like to thank him warmly for that. On top of it, he is going to talk about emotional dysregulation. Emotional dysregulation is part of neurodevelopmental disorders associated to ADHD, but not only, and possibly in France at least, is very little or badly recognized and treated as such. So Maurice is going to try to shed light on these conducts to follow and how to treat them. Thank you, Jean-Pierre. Thank you, everyone, and thank you for giving me this opportunity to talk about this theme. As you'll see, it's very complementary to the previous presentations, and it will shed light on a number of questions that were raised. Indeed, emotional dysregulation, and we'll see this is something you saw yesterday. We haven't mentioned it since. There's no link with this presentation, at least. So what are we talking about when you talk about emotional dysregulation? It's interesting because Jean-Pierre talked about behavioral issues, but not only. And we see that there are questions, recent questions on what we talk about what is the definition? And in fact, what are emotions useful to? When we talk about this emotional dysregulation, we need to know what we're talking about. We need to ask students or patients, and they don't know how to answer. This was set up to help adapt our behaviors. So let's not forget where we come from, nature, and the aim is to adapt in the environment we live in, and the emotional system, we will see, interacts with the behavioral system to adapt our behavior. And if this emotional system is dysregulated, well, it will have an impact that can be significant on the adaptive strategies of the person. It's a model of experience or emotional experience that will push you towards a purpose. And for emotional dysregulation, sometimes it's not well handle, and there's emotional stimulation as well. So the patient will be perhaps more focused or will crystallize among this emotional experience. So in the development process, and I will join Jean-Pierre for the development aspects, it can start at a very early age, and we can see that there are influences that are genetic, epigenetic, and you can be confronted to adversity, trauma, early trauma, elements of negligence, and this is where there's the issue of attachment and post-traumatic stress. We'll look at personality stresses. We talked about ADHD, but also the autistic spectrum can also contribute to give an additional impact on this development. And sometimes, what do we talk about? It's a mix of it all. So we see very clearly that depending on the issues, we can have different reaches that are different. So sometimes there are mix-ups about this emotional dysregulation that can be mixed up with the emotional ability or capacity, and we see that there's an overlap with these issues, and the balance between the prefrontal and cortex and amygdala, we will see there are different effects. In one case, there's the amygdalian system that will be impacted, and in the other case, the control prefrontal system that will not be able to control emotions. So it's a continuum, and it depends where you place the cursor, but indeed, you can have different specificities. I'm not a psychiatrist, only a pharmacologist, neurologist with a simplistic vision, and I believe that when we see complex patients, you need to have a simple vision if you want to understand things. Indeed, you see that emotional dysregulation is transdiagnostic, has a transdiagnostic dimension. I think this summarizes things in a simple way. So If we look at the control system, the prefrontal system and the emotional system with positive and negative emotions, we see we can summarize very simply the functioning of an individual. And this emotional regulation is found in different situations, addictions, psychiatric addiction, and behavioral issues. It can be chronic as well. There are chronic pain disorders, and this is common to and associated. The elements we see, so there are impulsivity elements, and this. So apologies. Yes, it's true that I'm going fast. Impulsivity elements with indeed a weak emotional modulation and a difficulty to come back to the basic situation. When you have you're experiencing Russian mountains or holocaustals of emotions, the produced strategy at some point will be an adaptative solution when we have this emotional dysregulation. Obviously, this will impact the quality of relationships to others, to pursue activities, and we see that in this emotional dysregulation there are also problems to recognize these issues. We mentioned yesterday alexithymia, when there's too many emotions, you're saturated, you don't understand anything, and it's difficult to understand and adapt things. If we perceive only an ill comfort, we don't know what's happening, the strategy produced is a way to adapt. Since it's very difficult in one's daily life, some patients have avoidance strategies, and sometimes it's easier not to be exposed or to be sedated. And we see that with the patients who presented by Wim and Gabi, there is this type of situation because indeed beyond the ADHD, we will see that emotional dysregulation is one of the aspects that can contribute to give a different color to our patients in the end. So it's a roller coaster ride. And if you go well, they can differ from one and part to the other, as emotions can differ from one patient to the other and a different context. Now let's come back to what Jean-Pierre said. And you say that this is very interesting. This shows the evolution of the... So this is a congress on addictology. We'll see consumption during teenage years, and we see all of the systems that implement during the cerebral maturation, the ward strategy, and the stress system. In this graph, people have forgotten others like neurodevelopment disorders and all the trauma that will have an impact and bring modifications and alterations in sleep. For example, we know that when they start at a very early age, the risk to consume is higher, and we'll see the strong connection between sleep and the impact on, well, TDAH and emotional dysregulation. Teenage years are risky, we know, for first consumption because our brain is super reactive. There's a system that is very, we see that the reactivity in the two social push and this amygdala, this connection that is implemented, if there are vulnerabilities, this system can go wrong, can impact the maturation and increase this emotional dysregulation if it already exists. As you know, the maturity of the brain is until 25 years of age, and all the things can happen beyond genetics and epigenetics that will contribute to modify the functioning and the construction and the whole system to adapt. Finally, you see that the structures we see are involved in the emotional dysregulations are the same circuits, more or less, than when you develop addictions. This is not just by chance, and the products themselves have contributed to create this emotional dysregulation if it didn't exist previously. And those who develop addictions, it's not just by chance, it's because there are already vulnerable elements that express themselves. So how can we assess it? It looks very interesting, but what happens in practice? In practice, in my consultations, when I assess my patients, well, I will use a scale with the difficulty emotional regulation scale, and with the DERS, and with 35 items and one scale. Well, there's one in French. So you will see this in literature and read that it happens with children's as well. What is interesting, I'm using the one with 36 items, and it's multidimensional. The whole interest of this kind of scale is that through the different items, there will be subscores. You can assess different areas, and the ability to be aware of the emotions, the emotional clarity. That is what we said before. Do I understand how I work and how I can accept these emotions? Patients who have very high scores will see the high impulsivity and all of the binge, for example, binging, binge eating, and we see this is connected to emotional dysregulation. The difficulty to engage in oriented behaviors. When you have these elements, it is obvious that it's interesting because there is a characterization or specificity of the patient through the scores and subscores. You can see the evolution during the treatment, and you can have different profiles, which means that the adaptation of the treatment will differ if it's pharmacological, non-pharmacological, and you can have an evolution in parameters. This gives the patient, and what is interesting is that I present the scores to my patients and I say, that is you. And they can have a reading on their functioning mode and how we can work, what we can work on together in a customized way. There are different aspects, and very clearly, we're going to see that the products are a strategy to compensate on what we cannot regulate on our own. Repeating consumption and amplifying these emotional dysregulations, having a bidirectional relationship. So when you see this bidirectional relationship between ED and addictions, you see it's going up and down emotionally. And our patients often don't use just one substance, but several. And in the end, we have a patient that is dysregulated more and more in time, and both aggravate mutually. The good news is that when we suppress or get rid of these fluctuations, we can reduce this emotional dysregulation, and that is important. And this needs to be kept in mind. For substitutional treatments with opiates, we can reduce this dysregulation in patients. Now let's add two other elements with our patients, and that were already mentioned in previous presentations: impulsivity and compulsivity. Here again, we often talk about impulsivity, but when we reach compulsion, it's never by chance. We know that there are pre-existing factors for this compulsivity, and they will contribute to make the person shift towards compulsive consumptions easier than others. And in the end, we have a whole group of dimensions. As mentioned yesterday with Marc's presentation, there are elements that intervene in the behavior and craving. Finally, you see that emotional dysregulation is recent in addictology. It's a paper from 23-24, and we feel we're rediscovering America. This emotional dysregulation is an atypical driver in the relapse use of products. And finally, we notice that this emotional dysregulation is a key part that will contribute to reducing the functional autonomy in a patient. And you will have understood clearly that there's this balance between the cognitive and emotional part that we talked about, self-regulation or self-medication, with the repetition of consumption and everything that's associated. You'll have this emotional deregulation with a patient that is modified. You see that the cognitive system is altered and the emotional system is completely dysregulated, which means that we will continue consuming and then using and different substances that we used in the beginning. So this dysregulation in addictions, we see that there are meta-analysis that show that it is present in the different types of addiction, whatever the products use, and also for people without products. If we look per product, we see that here again, there is very heterogeneous, and it wasn't, if it was mentioned for alcohol, depending on the studies, we will see some differences, but it is present. In any case, I would say when I meet with my patients, they don't use just one product. They often use several products, and often there is psychiatric comorbidity that can lead to emotional dysregulation. Rather than looking at each product, we need to look at the patient, because the patient is the one we treat and not the product. So this is essential, and it is true that literature focuses on the product. Can we treat it? The answer is yes. Otherwise, we wouldn't talk about it. It wouldn't be interesting. Pharmacologic treatments that can reduce anxiety, impulsivity, depression can help. All the range of antidepressants, but we see antipsychotic treatments that reduce this emotional dysregulation, like diprazzol, for example. And with opioids, these substitutional treatments can help reduce this emotional dysregulation. The fact of reducing the consumption itself, leading to these emotional roller coasters, could help decrease it. When there's an ADHD, we see that with specific medication, atomoxetine or methamphetamine, we see there's an effect that tends to moderate the mechanisms that intervene in this emotional dysregulation. So why doesn't it work for some patients? Thus, the interest to add other therapies and antipsychotic medication that can help. We see that when we put in place treatments, we stabilize them on different aspects, including those that we will see in a moment. And it's only afterwards that we see that there's an added value with the psychostimulant. Wim mentioned the TCC therapies. I would be interested what was the approach in this study, but there are all the other approaches, the TCD, a version or a derivative of this other for borderline personalities, but also applied for this emotional dysregulation, therapy of schemes, when this early dysfunctions, we can work on functioning schemes that we're not aware of and implement adaptive strategies and acceptation strategy. We see the whole importance of learning to accept one's emotions, not learning to being submitted or suffering from them. And it needs hindsight that patients don't have. They are impulsive. They want an immediate response, which is provided by the consumption of substances. And then there's a full consciousness that brings to other therapies and cardiac coherence and others. Let's not forget the essential needs. Sleep. I talk about it often in my presentations because quite obviously it is often impacted, and this is an added value. There's an intimate relationship with sleep. And this is why sometimes it's difficult to stabilize them. We see insomnia and emotional dysregulation contribute to the emotional adaptation. And their paradoxical sleep could be impacted as well. And this has an impact on the quality of life. And we know that this is true for young people. Thus, the importance to detect it at an early stage. So we wonder to what extent this reduction of sleep doesn't have an impact on people's relationships. And we should think about it because in the end, there's a emotional dysregulation, and we could have an improvement thanks to a specific treatment. In fundamental needs, eating, sleeping, moving. We know how much physical activity can reduce anxiety, depression, and can regulate emotions. Thus, the importance to have this activity for teenagers and we know how, to what extent it's important for people suffering from ADHD. It's important to promote this physical activity. And finally, eating food. We know that the microbiota is so important, how it acts through the, there's an interactions between gut and the brain, and can have an impact on craving. In conclusion, you will have understood that emotional regulation occupies a central place in a person's functioning, its ability to adapt, all of its cognitive emotions, and we see how it's important when a person matures, and we need to make sure that there are, of course, there are variations depending on individuals, but we need to look at it systematically, because it can happen in different types of situations. We see that for addictions, there's a bi-directional relation with a mutual aggravation that is associated to the main, central criteria, such as craving. It's important to assess. It's important to become aware for the patient, the caregiver, to understand one's own functioning mode, and to seek change for the caregiver, also to offer strategies that are customized or personalized. The importance of this assessment is an objective appreciation to assess the severity and the evolution in time. And we assess sub-areas as well, subdomains. So depending on individuals, we will suggest therapeutical adaptations depending on what was identified, whether pharmacological or non-pharmacological, and this is key for a customized medicine. Thank you very much.
Thank you very much, Maurice. That was fascinating. And because you have all respected the timings, we have some 20 minutes for questions. I don't know if Miguel CASAS wants to say something. Yes, Jean-Pierre, thank you very much.
Well, I would like to raise a question for all of you, Jean-Pierre included, or maybe to all the audience also. Why, in the year 2025, with hundreds and thousands of papers, scientific papers, showing us that ADHD exists and ADHD causes a lot of problems and can be reverted with a good treatment, why there are so many professionals in the field of psychology, psychiatry, pharmacology, and general medicine that denies and says that do not exist, and they induces wrong diagnosis and treatments for these poor patients, poor in the sense of that they are really dramatic problems. Well, what is your opinion, you know?
Je peux dire un petit mot pour la France d'abord.
May I say something for France? So in France, I have a personal experience because I am a pedopsychiatrist, and I have been working in a pedopsychopedagogical center for many years. And 30 years ago, when I met Emmanuelle Bouvard, who's a pedopsychiatry professor in Bordeaux, and she's a French specialist on ADHD, I invited her to talk about the recognition of the attention deficit and hyperactivity disorder. And when I proposed to the different psychiatrists of the region to come, well, many called me and told me that if I was doing that, if I was organizing that event, it would be a declaration of war. And I was wondering why. They said hyperactivity does not exist. It is an invention of the Americans and of the pharmaceutical industry. Now, the path to cover has been very long, and we have had some difficulties in France that have been solved, which is to admit treatment for adults, because now we can make children access treatment of methylphenidate. Up till now, it was the only treatment that we had. Now we have methamphetamines as well. But we could treat children, 6-year-old children, with methylphenidate without a limit of time. But the treatment was not yet updated, and now there has been some lobbying so adults can also access this treatment. Now I see that there have been many studies, and I see that less than 15% of ADHD are diagnosed and treated in France. And I have to say that pedopsychiatrists and their teams were rather oriented to psychodynamic and psychotherapeutic approaches, and they were very reluctant regarding pharmacological treatment. They were reluctant, they didn't know about it, and they were very reluctant to treat children with pharmacotherapy. And maybe I can say something as well regarding the French situation. We're talking about this emotional dysregulation and the lack of awareness. It's the same for ADHS. And there's this lack of recognition. We see now that the interest is raising. And now there are some training for professionals, but we see that initial training does not prepare professionals for ADHD and the problems that patients are facing. And now to get some training is a voluntary act. And we need these problems to be better identified, better treated, better understood. But it's all very recent, and we see, as you said, that there's a lot of background behind. There was a lot of reluctance by professionals themselves. They didn't want to recognize this kind of problematics. We're talking about ADHD, but we could say the same for addictions. And actually, there's been a big lack of recognition.
Well, I think I totally agree with your comments. Is this okay? Yeah. What I see, what I'm really pleased seeing the publications on adolescents, for example, and from the pediatrics literature, looking into the influence of methylphenidate and questionable growth retardation, which is not the case, looking into the gut-brain axis, looking into sleep, looking into emotional dysregulation is getting more difficult, but also looking into cardiac side effects on medication maintenance. So there is really, I'm pleased reading this literature, and there is a lot going on. And there are some countries who are really do a lot, like Canada has a really great network on this and studies. UK actually has been focusing on this. But what makes me disappointed in the real world situation, that there are countries of having this structured substance use or the addiction clinics and having here ADHD clinics. And basically, it's within the psychiatric spectrum, and it's not rocket science to diagnose ADHD. And it's hardly any other disorder so rewarding if you treat people with substance use disorder. And what I keep be compliant with your guidelines. I use long-acting amphetamines, It's working nicely, it's beautiful, it's a relief for the patient, it's a relief for the family. And what I find interesting, where we need to actually do translational education and research, is, for example, the food addiction. It's hilarious. Everybody is on GLP-1 agonists or glucagon agonists if there is an obesity problem. Great. But if you diagnose ADHD and put them on lisdexamfetamine, you know, you see on a clinical perspective how they maintain the body weight if they have the treated ADHD. But we lack studies. And why? There is a major problem in funding. Even if I approach the companies who provide all these GLP-1 agonists, glucagon agonists, they're kind of reluctant, you know. We want to go into obesity. We're not going to be touching mental health. We don't like this. But now they seem to open a new brand on mental health because seeing the efficacy on alcohol use disorder, and it might be an option that the medication is registered through FDA on alcohol medication. It's even more, you know, if we keep interacting with endocrinologists to look into the topic, and it's very easy to screen it. And what is the reason? I can't really understand, because I understand the stigma on so-called addictive substances. But if we go back to Tom McClellan or Jack O'Brien, when they were publishing their paper, yes, addiction is a chronic relapsing disorder. It's like hypertension, it's like diabetes, so we're gonna have some maintenance treatment. It's the same with the amphetamines deliveries. I would love to have a more active involvement of the industry, because I see a lot of activity by the ketamine treatment, but of course has an addiction potential as well. But I personally think there is a lot of resistance because of the past facing figures of not being compliant with the rules. But I have been treating, for example, over 10 years maybe, people on opioid maintenance plus lisdexamfetamine, or also stimulant dependence. It works nicely, and that's no risk of really misuse the medication. On the clinical basis, I rather see that some patients, they're not going to be whole for 24 hours on the long-release version. So they need additional medication. But that's a clinical model which works. And I think the study Wim presented is important, the field study. But I also would say we would need more controlled studies on that.
Maybe last comment. It is really a problem, because to convey a message to the general public, this is a difficult one. I think in many countries there is both underdiagnosis and undertreatment, and there is overdiagnosis and overtreatment. This is a complex message for the general public. It's also complex for pediatricians, it's also complex for psychiatrists. So where do I position myself in this whole debate? Because you don't want to overtreat and you don't want to undertreat. So where do I stand? And so the only thing you can actually refer is to very clear regulations. And so a diagnosis is not made only with the patient, and definitely not only on instigation of a teacher. You need a decent diagnostic process involving key persons in the child or the adult environment. So you don't go from one day to the other to the treatment of, I think we should recognize, with serious medications. And definitely in kids who are in the development, you have to control blood pressure levels. You have to control the development of the sexual development. You have to take it serious. You have to take parents very serious. You also have to be flexible as a doctor. Some patients will use it for a long period because they feel good at it. Some want to make all kinds of changes during the week. And I move with these kids. I move with, if they don't want to use in the weekend, it's perfect with me. The fun with the medication is that if you take it, it works. You don't have to wait for 7 weeks like with antidepressants. So if they want the weekend to go out of their head and you have an agreement, you do it. And so it's a lot of fun working with these kids and the parents. And like Gabi, it's so satisfying. The results are often so immediate. And the function of the family, it's amazing what happens to them. So, and then we see that it's not only has it positive effects on making the risk to develop substance use disorder, it also has very good effects on reduced number of accidents, reduced number of criminal activities, a reduced number of, so it's on a wide range you see improvements. So what else you have to say? It's the most effective treatment that we have in psychiatry. Maybe it's one of the most effective treatments that we have in medicine. And it's amazing that we fail to use it in different populations. And I just have a strong message from the randomized controlled trials, but also from our naturalistic study that it should be used more in addiction treatment.
All right, we're now going to give the floor to the audience. I cannot see. I think there's a hand raised over there.
Hello?
Oui. Okay.
Thank you so much for this wonderful series of presentations. I have a question for Wim about your study and one of the findings, which is I thought it was interesting that most of the people got prescribed stimulants were already abstinent. So wouldn't you expect, doesn't that make it difficult to figure out what their effect was on their substance use since they started out abstinence? Wouldn't you expect their substance use outcomes to be better because they started out better? How did that all work, or did I misunderstand something?
Yeah, so the numbers that I provided was whether they came in while they were using substances or in the first 4 weeks. That in the first 4 weeks, we defined what kind of treatment they got. So what you see is sometimes patients that come to addiction treatment, they already reduce their substance use before they come in treatment. They seem to prepare themselves, and quite a lot of them actually are available to do that, are possible to do it. And or otherwise, some actually reduce, especially when they're in inpatient treatment, they reduce to zero. And it seems, and we also got it in our, we did the recommendation based on a survey among practitioners. There it also was that they're afraid if they're still using stimulants that starting stimulant treatment would actually make things more difficult. And so it is really a question. I think it's not out in the open there what you should do, but the data that we have in the randomized trials also show that while people are using cocaine and they have ADHD, starting a long-acting medication will actually improve or reduce their stimulant, immediately acting illegal stimulant use. So that is, I think, the message that we have to send is we're not to replace the one acute acting stimulant with the other acute acting stimulant. We're replacing, in that case, I may also say, we treat the ADHD with a long-acting stimulant, and maybe we're replacing, we don't know for sure, also we're replacing the acute acting illegal stimulant with a long-acting legal stimulant. We probably do both. We do treatment of the ADHD, and we do also substitution treatment of the stimulant use disorder.
Question courte et réponse courte.
A short question and short answer in order to be able to discuss as much as possible. Hello, everyone. Kariba Kuba, Addiction France. 2 questions. Thank you very much for all these very interesting presentations. First, on the treatment of ADHD, you clearly highlighted and described the low access to treatment for multifénida for people suffering from addictions, whereas today, ANCSAPA and doctors who are not neurologists, psychiatrists cannot prescribe this treatment. So how come this is something that is blocked, and how can we get more access? Because it is difficult to find the way, and even people are not necessarily aware of these solutions, and it's a real problem. Second question for Professor DEMATTEIS. I was very interested by your presentation, as usual, very well illustrated with these different drawings. So do you have a notion of study or experience that uses EFT, the emotional liberation, so that helps people to go into remediation, to channel their emotions, and they can work on psychotraumas? When you're trained, it's quite easy to apply, and this can be useful for other tools to self-heal for patients.
So I'm not completely aware of the treatment possibilities in France or Spain. I can talk from the Netherlands and some other European countries there. It took a long time before stimulants became available for the treatment of adults with ADHD. It was in most countries, it was available for children for a long time already, for 20 years. And then it took a long time before it became available for the adults, and then it took a long time before the long-acting became available and reimbursable to the adults. And I'm not sure how the situation is in France.
Well, I don't know. Obviously, it's a problem in France, but what I experience all over Europe, there's a huge heterogeneity. As in some countries, it needs to be a professional psychiatrist or pediatrician to start the induction, and then continuously family doctors can prescribe it. And it's probably the same in France, and it's very disappointing in some of the neighboring countries. There's even not methylphenidate available, what I've been learning, you know, outside the European Union. It's kind of very easy in the United Kingdom because it's a long tradition, but as you were also pointed out, it's not rocket science to diagnose it. I think it needs to be a much lower threshold if we have opioids prescribed through GPs, what is very important. Of course, we always can discuss quality about quantity, but it's a huge range. But there is a consensus that is a highly undertreated diagnosis. And what I always try to educate, therefore I showed you the book of Gabriele FISCHER, a psychiatrist, substance use, ADHD, treatment, children with it. He is educating all over to teach a lower access, because if we have this problem that psychiatry are not that easily available, the same I face in some European countries already with pediatricians, in order to cover the disorder, it's a policy thing. And what might help is addressing this to the politically responsible people, the high costs related to the untreated disorder. And what also helps, what I keep using if I'm invited to sex and gender meetings, you know, there's a high range of intimate partner violence. So we need to get other disciplines in it. We need to talk to OBGYN, for example, to look into this as well.
Alors, je vais me permettre du coup d'apporter un éclairage français. Alors, vous pointez du doigt un vrai
shed
paradoxe.
light on this in a French way. You're pointing out a true paradox. It's true that, as you said today, psychiatrists who are supposed to know don't all know everything and don't necessarily know what they can prescribe, and addictologists are confronted to these issues that are frequent. It's at least 25%, so 1/3 people. So if we are not a psychiatrist or a neurologist, you cannot prescribe the treatment. But those, as for addictology, I didn't mention pediatricians, but you're right, Jean-Pierre. While practitioners who are confronted frequently to these issues today do not have the possibility, the regulatory possibility to prescribe. There are obstacles at different levels. There were works done by the national coordination, but there are obstacles, and if we want to move forward, we would need to enable prescription of treatments by those who meet with the patients. We are sometimes solicited just because there are people who are trying to have an assessment and cannot find it, and they need professionals who should be supposed to provide an answer. There are strategies. The problem of psychotherapies, well, TCC has a democratized TCD. Not everybody knows how to do it, although it's a derivative of TCD, the two great psychotherapies that are adapted, and TCDs developed historically by Linehan, who was borderline, and applied it first for personality disorders, but also to showing that it worked with emotional disorders as well. These are techniques that have been validated and with proven efficiency. And then you see that there are other approaches that we can offer in other structures, even if we don't have a specific training on these strategies that we can offer to our patients and that can improve their functioning in everyday life. When you improve the global functioning on basic needs, you can greatly improve the patient's functioning, and without anything sophisticated. What you need to bear in mind is that everybody can do something. You don't necessarily need a treatment, but it is helpful. You don't necessarily need pharmacological treatments, but when you restructure the patient's functioning, we see things more clearly. So we are going over time, but it's okay because we're the last ones. Jean-Michel, you have a question? A short question and short answer, if we can. I will take advantage. I think I have two questions, so thanks to the panel, it was great. I'd like to turn to Maurice. I'm a psychiatrist with a training as a neuroscientist as well. These categories of diagnosis are interesting. The one you mentioned on emotional dysregulation, but in psychiatry, what is not recent is the emotional reactivity, emotional instability that are essential diagnosis criteria for the borderline personality that you mentioned before. And we know the strong comorbidities with addiction, and thus in treatment offered, we see the mood regulators, and in psychotherapy, as you said, there are the different therapies for borderline personalities and the therapy of schemes. So two questions. First, the link or connection between personality disorders, emotional reactivity, hyperreactivity of the stress system, and previous stress. Why don't you add therapies that are focusing on the scheme that are used for these issues? And the second question, Marc Potenza, yesterday, the first time I saw him, I was delighted because we quote him often, and he showed there were gender differences in the frequency of this type of questions. And you talked about patients, male and female, and Marc Potenza and other American studies shows that the trigger for craving, rather for women, will be an emotional hyperactivity, feelings of aggressions, humiliation, and maybe there should be more attention on that. Yes, you're right, and our patients, these are chimeras. There are many things that are intermingled, and up to us then to have a gradual vision that helps to see things more clearly by going there progressively, because the patient we cannot manage everything. It's difficult. And by prioritizing a number of things, we see that there are psychotraumas we cannot treat immediately because they're not in the right condition to do so. So they will be involved in dysregulation, but we will take care of that after having stabilized the patient on other aspects that will help the patient to be in the right condition to work on other more sensitive aspects. You're right, and this is why I would say beyond gender, some men will have similar things that look like what women experience. But when we look at addiction, this is a definition or qualification or have a mapping of the patient's psychopathology. And then, as you said, to be able to eventually, if available, add strategies. But the problem is the availability. We see that today in the psychotherapeutical strategies, it's very heterogeneous. We see that TCC is democratized, but for traumas, complex traumas, as you mentioned, some psychologists will be trained, others are not trained. One comment.
It's an interesting thought that we should stabilize people before they do these active treatments like with EMDR and so forth. I think that has been the proposal for many years, like staying safe. And I think there is actually quite good evidence now. This is not a way to go. Because staying safe and first having a phase 1 treatment where stabilizing is the theme, and then waiting till the time, a lot of people drop out. And it turns out that even patients with serious traumatic experience actually do very well in EMDR. So I think that we really should also consider the position that patients with these kind of symptoms, because if you have a patient with these kind of symptoms, like measured with a DERS, if they have traumatic experience, I think early exposure, including EMDR, is probably the right way to go. You see a lot of these symptoms, including borderline symptoms, disappear after that. And you don't lose them on the way. And what you, I think, already said, if I understood you well, we can wait till all the kind of psychotherapies, like dialectical behavior therapy. We just don't have the capacity, the treatment capacity for these activities. So go for early treatment of psychotrauma in our patients.
Just to close, I would like to ask a question to Wim van den Brink on, yes. So one question for Wim. We talk about this in France. There's a whole discussion. You said that in the framework of a comorbidity for a usage in cocaine and an ADHD, if we waited too much to prescribe psychostimulants to treat the ADHD, what we even suggested are studies in order to attempt or to try to use methylphenidate with cocaine addicts, patients with the cocaine use disorder, as a treatment of substitution. The works that we have are known are numerous, and we saw that it didn't work as a substitution treatment for cocaine. So we're all looking for this treatment, and I would like to have your opinion, since what we know is that in the framework of a comorbidity with a cocaine use disorder and ADHD, it's legitimate to prescribe methylphenidate for the ADHD, but rather we wait for 2 months of abstinence of other psychostimulants, cocaine and other. We wait before starting prescribing methylphenidate. What do you think about this?
It sounds the ideal treatment, but it's rare that in my treatments I can do the ideal situation. I have to deal with the patient that is there, and waiting 2 months for treatment with cocaine-dependent patients, I have 90% probability that he's gone already. So I'm not sure that I would wait 2 months. There's two things. One, you can treat with methylphenidate, but you don't do substitution of the acute acting illegal stimulants. You use long-acting methylphenidate. That's the big change. Like we do in methadone. We don't use short-acting opiates. We do use long-acting opiates. So start using long-acting stimulants, either methylphenidate or dexamphetamine. And you have to be willing if people don't respond well, to go to higher dosages, like going to dosages of up to 180 milligrams or even higher with methylphenidate, or going up to 80, 90 milligrams of dexamphetamine, or maybe even higher. Not in all patients, but patients who don't respond. And why? We did a study looking at the binding of methylphenidate to the dopamine transporter in patients with ADHD and in patients with ADHD and cocaine dependence. And it turns out that if you take a standard dose of methylphenidate in these two patient groups, you have the same concentration in blood plasma. But if you look with SPECT scan at the dopamine transporter, you have much lower occupation of the dopamine transporter in the comorbid patients. So you probably have to use higher dosages, not in all patients, but in many patients, you need higher dosage of the long-acting stimulant. And that is how I should go. So I don't wait 2 months, but I'm losing my patience. 2 months is like eternity for a cocaine-dependent patient. So,
but just to add, actually, the studies showed that the amphetamine is superior to the long-acting methylphenidate in cocaine dependence in ADHD. So this is long-acting amphetamine is more efficacious than methylphenidate. Yeah.
Yeah, there's at least studies from both that shows, but you need long-acting, and you might need to use higher than standard doses.
Très bien.
And control about abuse and misuse, of course. And so you don't start with repeat prescriptions. You see the patient every now and then. And so make sure that there is no abuse and diversion. I don't think that the risks are so big, but everybody talks about it. And so be on the safe side and do some protection of misuse and diversion.
Merci. Juste une petite dernière question, peut-être si vous...
One last question, if you may. A very short answer, because we went over time. It's 1:15 and we were supposed to stop at 1. Thank you for the answer on comorbidities and how we can manage the psychotrauma aspect with ADHD and everything that can come with emotional dysregulation. My question is a bridge between the treatment and we talked about methamphetamine for typologies, such typologies. Is there a positive impact on the emotional dysregulation? Is there a positive impact on the long term and to improve this dysregulation? And the second question is, are there secondary effects that can be noted that can be worrying for the long term? Thank you.
Short answer.
There are no studies. There are no studies. There are no studies on this.
So
y a pas d'études. No.
Start doing it and write some nice case reports. It's a good start.
Bonne question, mais pas de réponse documentée.
So very good question, but no studies. Thank you very much to all the speakers. I think it was fascinating. Thank you to the audience who stayed here until the end. Thank you very much.